First of all, thank you all for being here, and I want to first thank Patrick Kennedy for his incredible leadership, stalwartness, bravery, and honesty in bringing together this community. And I love the tagline, community of mental health. It's a wonderful way of putting it. I had the privilege of being with Patrick about 7 or 8 months ago in a small gathering of individuals who were struggling with parity-related issues in Connecticut. And we were listening to the testimony, really, of families whose kids were in emergency rooms, not being cared for, struggling with a whole variety of very, very difficult issues. And we had a chance to talk afterwards. And his vision of bringing together everyone with a common vision, common purpose, and I think a common language, which has begun here today and yet last night, is really something for all of us to welcome and to relish his leadership. So thanks to him and to the Kennedy Forum. I want to take a moment to introduce this panel and then the topic that we'll be covering. I think the issue here is really, how will we know that we're succeeding? How will we know that the work we're doing really affects real people on a day-to-day basis? What are the policy initiatives that need to be attended to? And how can we make a difference to both measure those policies and make sure that those policies are the right ones? And what do we need to do to advocate around that? Because we have a lot of important leaders here at this meeting, and we need to think about the next steps going forward. So I want to introduce in order Connie Garner. To my immediate right is the policy director and practice leader at Foley Hoag, which is a law firm both in Boston and Washington. She is, by training, a pediatric and neonatal nurse, and she still practices, which is a wonderful thing, and keeps it real for all of us. And she has also served for 17 years as the policy director for disabilities on Senator Edward Kennedy's Help Committee, and was very, very deeply involved in the work leading to the Parity Act of 2008. So welcome to you. Rhonda Robinson-Beal, to my immediate right, is a psychiatrist. She's the Chief Medical Officer of Optum Health Behavioral Solutions, and has been a national leader in a whole host of areas, particularly related to quality and how do we improve quality, not just in mental health care, but all of health care. She's been part of multiple IOM panels, including the very important Crossing the Quality Chasm panel, and has worked as a consultant and with both NQF and SAMHSA. Glad to have you with us, Rhonda. Sherry Gleed is currently Dean and Professor at the New York University Robert F. Wagner School of Public Service. One of the books that she wrote was mentioned earlier. I think it's Better But Not Well. Better But Not Well. Prior to her, and she's an expert in all sorts of things related to public policy, prior to her taking this role at NYU, she had the wonderful title of being the ASPE, one of my favorite of all, which is the Assistant Secretary for Planning and Evaluation in HHS. And I think it says something about HHS and this administration that we've had someone of Sherry's background and leadership in that role. And then last but not least is Tom McClellan. Tom's the CEO and founder of the Treatment and Research Institute at the University of Pennsylvania. And he has been a leading researcher in substance use illness. He also served a tour of duty as the Deputy Director of the Office of National Drug Control Policy in the White House, and will hopefully be speaking to us both about policy science and the implications of all of this for our advocacy. So I want to turn it over to Sherry first to give us some perspective about the next 8 to 10 minutes or so about the policy process, how she thinks about policy, and how we can begin to frame a conversation together about policy going forward.
So thank you very much, Paul. I'm really delighted to be here. I was just thinking about it. Mental health policy is a really interesting area to work in because the problems are so difficult. Richard, Frank, and I wrote this book together, and at some point in the process, we realized all the difficulties there are in studying health care, health insurance, all of those problems are just magnified in the mental health arena. This is a very, very difficult policy problem. And then to see such a difficult policy problem, actually to see progress being made through a combination of advocacy and policy analysis, people like Patrick Kennedy, people like Howard Goldman, other people on this panel who have really moved the needle forward. It's really a wonderful area to work in because I think it is an area for optimism. So with that in mind, how might we think about how we're doing and whether we're parity and the other things that we do actually make a difference. So I was asked to start thinking about, is it working? And when somebody says to you, is it working, the question you ought to ask is, what is it? And what is working, right? And here, I think one of the challenges for us is to really think about what is our objective as we think through a law like parity and a problem like mental health policy. And if we think about mental health policy and the law and the parity law, for example, why did we go down this road in the first place? What was the problem that motivated advocates and analysts to start thinking about parity? And I guess there are a couple of problems that you might think of, because nobody ever articulates it quite that way. So one was just a simple issue of fairness. It just doesn't seem fair. But beyond that, the fact that people with mental health problems were facing extraordinarily adverse financial consequences of having those problems, catastrophic financial problems because of mental health, the fact that people didn't have adequate access to mental health services, all these different motivations at a very broad level that sort of led to people thinking about about parity as a way to solve it. And then, what is parity? Parity is an idea that mental health ought to be treated the same as physical health. So that's a big, pretty broad policy idea in itself, and a very attractive one, because it allows us to speak in a language of rights, which is a really good language for us to talk in. But it's a policy goal. And then there's a parity law, which is something within that policy goal, but not quite the same thing as either of the things that came before it. It has to be narrower because it's the product of a legislative process in which people are arguing back and forth about what parity is going to cost and what it's going to do to employers and whether it's the right thing to do now. The parity law, I read it again on the plane down, is a model of clarity. I mean, it's not like the Affordable Care Act. It actually does one thing, and you can see what it does. So that's a wonderful thing. But even there, if you're a small employer, you're not covered. If you drop your mental health and substance use services, that's okay. If it costs more than 2%, you get an exemption. So it isn't exactly the law that you would have written if you were the dictator and making that policy goal work. So I think it's really important to think about all those three levels as you think about implementation and whether things are working. So first of all, you could ask, are we complying with the letter of the law? Are the regulations that the law specifies being written? Are the enforcement actions taking place? Is the budget there to do the things that the law says? And that's one set of questions. And then, there's the set of questions about, are we getting closer to parity? So are we actually seeing more similarity in the treatment of mental health and substance use services? And there's some evidence that's also true, that we are seeing that. But then the broader questions, are we actually seeing improvements in access and in financial protection? That's yet another layer. And you can see that having one thing work doesn't mean that the other ones work. So we could have people complying with the letter of the law by dropping their coverage. That would be complying with the letter of law. It certainly wouldn't be achieving the narrow policy goal. And we could be achieving the narrow policy goal of equal access to mental health and mental health and substance use services and physical health services by making access to everything terrible. So we could just give everybody $50,000 deductibles for everything, and then they wouldn't have access to either mental health services or physical health services, and we'd have parity. But we wouldn't have achieved our broad policy goals of providing people with financial protection and access. Similarly, if we gave people adequate access but there were no providers available for them, we would have achieved the policy goal, but we wouldn't have gotten to where we want to go. So I think it's actually important in thinking about policy to think at all these different levels. As you do the analysis to see whether it's happening, you look at different things. So you can look at people like the General Accountability Office, the Office of the Inspector General in HHS, advocacy groups look to see, are the regulations coming out on time? So we heard the Secretary yesterday saying the final parity regs are going to be coming out very soon. That's an encouraging sign. It's something you can monitor. And you can monitor the budget, and that data is pretty available. The second set of questions about, is this really getting us to parity? Are insurance companies behaving the same way towards mental health and substance use? Much harder to get at, much harder to see it. You have to actually be doing very detailed, specific kinds of data collection, collecting information from lots of people. ASPE at HHS, one of the projects that people there worked on was trying to look at this, and the studies that we did there suggested that, yes, indeed, we do see evidence that employers are complying with the parity rules. Things are moving in the direction that you'd like to see. But what about the broad measures? Actually, the nice thing, I think, from a policy perspective is that those are relatively easy to get your hands on if you just look for the right things. So we should be monitoring on a regular basis, how much do people with mental health problems spend out of pocket on health care? How does that compare with how much people with diabetes spend out of pocket on health care? So we can do the kind of parity comparisons, not at the level of the regulation, but at the level of the outcome. Do people have to travel farther to find a mental health provider when they're hospitalized for a mental health condition? Are they farther away from their families? Do they express the same kind of satisfaction with services? So there's lots of things that we routinely measure as Howard said this morning, in a non-exceptionalist way. We do this because we are measuring this across the whole population, that we really could be monitoring and probably should be monitoring to be thinking more about what's going on. And if we see that things are not happening at that macro level, we could ask questions like, was parity the wrong policy? I don't think so, but perhaps. Is it a poor implementation of parity or ineffective implementation? Or more likely, do we need more? Is parity a first step that we need to go beyond? I think the ACA is a huge step beyond parity because it fills in that hole that says you don't have to offer this coverage at all, or you don't even have to have insurance, right? So it fills in an enormous gaping hole that was left. But parity was totally essential to getting the ACA to have that piece in it. If parity hadn't happened, I cannot imagine that the ACA would have put parity in by itself. But what else do we need to do beyond the ACA, beyond parity? We need to be looking for those new opportunities for advocacy and policy analysis. Are the services there? Are they accessible? Are they effective? Do we have housing and jobs for people with mental illness? We can't stop with just the medical services. And one problem that I think I'm particularly interested in is how are we treating the fact that mental illness is often a family problem, not just an individual problem. All of our service systems, all of our financing are set up around individuals. How do we move in that direction? There's a new policy problem that we could be thinking about. It's because we've made progress that we have new problems to deal with, and that's a great thing. So let me stop there.
Thank you. Thank you. So, and one of the questions that I hope we'll come back to is, you mentioned that this, when you and Richard were doing this work, that all of these complexities in healthcare policy in general kind of reach kind of a culmination. So I guess one of the questions is, and I think it relates back to some of the things that we will be talking about, why is this so hard? What makes this a harder house to play in, if you will, than dealing, let's say, with cancer care or diabetes care or some other area of healthcare?
So, there are a couple of things that make it really hard. One is that these are chronic conditions. Chronic conditions are always difficult to deal with, and conditions that are intermittent, which I think mental health conditions, not like diabetes, you don't necessarily have symptoms all the time. You have symptoms intermittently. Those are particularly difficult problems because you're well and then you're not well, and the way our insurance system and many other things are set up, that's a problem. The second problem, quite frankly, is that our treatments are not nearly as unpleasant as many of the treatments in other conditions. And that actually is a challenge from a policy perspective. If you offered people free chemotherapy, not a whole lot of people would be lining up. But if you offer people free psychotherapy, there are going to be a lot of people seeking services. And that is a totally, at least the experience has been, if you look at studies that have been done, people are much more sensitive to the cost of psychotherapy than they are to the cost of most other things, which suggests if you lower the price of psychotherapy, there's a much bigger effect on demand than there is with other services, which is why, that is a characteristic of mental health that's been around for a long time. Some kinds of mental health are more difficult than others, and as we move to those, you have less of this problem. We don't have this problem with antipsychotic drugs. But the whole field is affected by the fact that it isn't a terribly unpleasant thing. And that's a great thing. That's wonderful, but it does make the policy problems more difficult.
So to the chronic illness, Tom, you've worked in the area of substance use and the issues of how much we treat things as an acute care episode in a silo versus a chronic disease model integrated in with the rest of healthcare. Sorry. How does the policy begin to change as we move from more of an acute care to a chronic illness model? And how do we begin to think about this as something that doesn't exist off in a vacuum by itself, but is really embedded with mental health care and with the rest of healthcare in general?
In the substance abuse field, I think, first of all, ACA and parity, there is, I'm sure, no illness that is going to be more impacted by the ACA than addiction. Because addiction, first of all, was not really considered an illness for a very long time. And it went from being in the, not even shadows, in the darkness, to being an essential service. Now, that fact, I think, swamps everything else. Now that it's integrated or going to be integrated into the rest of healthcare, it opens a door for things to change in ways that are tough to predict. Gone will be the days where you go away to some box out in the country for 30 days of care and you will be expected to be fixed when you leave. You will be receiving care probably from your primary care doctor and managed over the long term with help from your family and a cohort of people with your illness in much the way that they're now managing getting towards managing diabetes. That's a big change. And with it, we need, back to your point, how will we know when we're successful? Well, we have known for sure that we're not successful because we have a high relapse rate. Well, that happens when you give somebody an acute period of care, stop it, and then wait for somebody like me to come around 6 months later and see if they're fine. They're not fine. We need a measure of disease control. We need hemoglobin A1C. We need 130/80. We need, the same kind of measure that will track during the course of care legitimate improvement and success as other chronic illnesses now see.
But knowing that the statistic that was mentioned earlier this morning and yesterday, that only about 10% of people who have substance use illness are getting care, what are the implications of? And the ACA, I agree, has extraordinary, and I'm not sure people all completely realize just how extraordinary the ACA is around mental health and substance use care and how potentially transformative it is. But the access to care, the availability of care, we've got a lot of non-evidence-based care that's going on. How do you begin to see monitoring that process? The
other tremendous thing about parity and ACA is it's not just addiction anymore that's being insured. Imagine an insurance benefit for diabetes, where in the interests of husbanding scarce resources, you only treat people, you only insure, you only reimburse for people with real diabetes. They've lost their fingers, they've lost their eyesight, okay? That would be preposterous. You wouldn't have any nutritionists, you wouldn't be teaching it in medical schools, etc. Well, that's the way the addiction benefit has always been. And with it come remarkable implications from that. Everybody talks about stigma. We purchased the stigma. We bought it with the way we segregated and insured and evaluated the care that we gave. We made sure that only the most complex, chronic, serious cases with the worst prognoses would be treated. That's the only ones you could get money for. They weren't treated with everybody else. No. They were treated in special programs, down there across the railroad tracks. And thus, we have stigma. Well, with the integration, with treatment of the same nature, I think you're going to see a much broader array of people come in with substance use disorders, not just addiction.
So, Rhonda, you have the challenge of living in a large, important insurance system, the Optum system, the United Healthcare system, which has a lot of individuals that you're responsible for in terms of their insurance, but also working with the field to figure out how all of this actually begins to play out in a real-world kind of way. And what are the challenges that you face? How do you begin to bring people together to solve those challenges? And particularly, maybe you could talk a little bit about non-quantitative treatment limitations, which is really one of the distinct elements of the parity law that I'm not sure is always well understood or not always clear exactly how that gets monitored, articulated, and defined.
Thank you, Paul. It's the area that I live and breathe that keeps me up at night. And it's an area that I think is one of the most important parts of the parity law. I want to say, first of all, thank you to HHS, to Richard Sherry, for the work that's been done on the parity law, particularly in trying to articulate non-quantitative treatment limitations. Essentially, you had to start with a blank sheet of paper and try to describe the nuances of treatment limitations that had nothing to do with finance, okay? So there's the quantitative and the non-quantitative. And I think it really took a lot to be able to articulate the way it has been put together in terms of looking at how to define parity as it relates to medical. And so I think with the recent, as of November 2011, FAQs, there became more clarity as to how to do that. So essentially what it helped, at least those who are trying to operationalize this, to be able to understand how do we look at behavioral and how we look at medical. What we did to do that is to look at what medical does, and for us it was a chore. We had to go through plans for 106 medical plans to really look at the nuances of how they manage utilization management, what tools they use, what philosophy they use, what thresholds they use, because the FAQs gave that kind of guidance. And in doing that, it helped us to understand how to make the changes as it relates to the behavioral health benefit. One of the things that we noticed with that right away, hits you right up in the face, no more visit limitations, no more day limitations. You don't know how happy we were with that, because so many times we were faced with cases that came up against a benefit limitation and there was nothing else that we could offer at that point other than to send them to the public sector. So that's no longer there. So the phrase that we use internal is that the public sector, we are now the public sector for those who have insurance, which has now opened up the doors for us to widen the scope of the type of services that we can offer. We are now working with peer groups to bring peers on board as part of the delivery system. We're also looking at wraparound programs, which we didn't have the option, or we didn't have to do that in the past because of the day limits and the visit limits. So I think it's been a tremendous change in terms of how we look at utilization management, how we look at expanding the network, and really focusing in on behavioral health as a chronic illness and having the system that is there to support that. I think the area that becomes still a problem, and this is an area that I have a cry out to the community, okay, is when we started looking at areas where, and I think people here on the panel will agree, where we don't necessarily have evidence or know how to treat or how to help an individual with certain conditions in certain situations. And then that's where it bumps up against this whole medical necessity issue that people hear so much about. So what we're doing now is that we're looking at the very complex disorders. Eating disorders is the one we first started with, where we're bringing in the researchers and the research that has been done. We also have brought in our high-volume providers to say what works, what type of systems work. And more importantly, we brought in consumer advocacy groups, and we've done survey with them to say, your experience of treatment, what worked and what didn't work. What that's going to help us to do is to identify the things that need to be available from a systems perspective, what needs to be available from a provider's offering of services. For example, training as it relates to eating disorders is exceptionally important. Going to a generalist has less good outcomes than those who have been specifically trained. But looking at that, it helps us to understand what are the things that need to be in place in order to really deliver best services. And by bringing those together, we're also finding the gaps. So the gaps are, and I turn to the researchers, I turn to the providers, tell us what we need to do with these gaps. When we have cases that hit these gaps and we're hitting up against medical necessity, I want you to tell us what we need to do. We as insurers don't want to make those kinds of decisions without the evidence, without the consensus that is really out there in the community, because we feel that is what has happened with parity. It has opened that door and it's made those situations quite evident, and also things that we as an industry need to deal with.
One of the questions that sometimes comes up is exactly what those standards are, what the medicalness. As you develop and build these standards, one of the challenges we have with both parity and the ACA is monitoring how well we're doing. And it's hard to know how well we're doing if we don't know what the metric is against which we're being measured. So are those kinds of standards going to be ones that are held privately? Are they going to be published? Are you and other groups publishing those or getting them out there so people can know what the criteria are that they need to be thinking about?
Paul, that's an excellent question, and I think you hit the nail on the head. It is transparency that's exceptionally important. We've invested a lot in terms of at least starting, okay? with measuring performance as it relates to quality as well as efficiency. Now, they're not perfect measures, but what we're doing is working with, again, the researchers, the providers, and consumers to say, how can we change this? One of the things that's a huge stumbling blocks is the lack of adoption of electronic medical records, which would give us a lot more information that will help us to be able to differentiate the population, the severity. But without that, we're really relegated to claims information, which is very one-dimensional and has a lot of flaws. One of the major flaws that we have, and we've been going out and actively talking about this with provider groups, is that there is a belief amongst providers is that you only put the least discriminatory type of diagnosis on a claim. And by doing so, what you're doing is you're underestimating or underreporting the severity or the complexity of a particular patient. And this is just what we need right now, is to understand those who are complex and be able to look at those that are complex and really figure out what is needed for that population. Without providers putting all the diagnoses, I know we're going away from the axis 1 to 5, but putting axis 1 and 2 and 3 diagnoses on it, we're able to see that people with, for example, we've done studies where people will have an axis 3, which is a medical diagnosis with a chronic medical illness, and a behavioral health diagnosis. Those individuals need longer in treatment, much longer in treatment in order to respond. But it's not until we have that kind of information we're able to have the data to be able to demonstrate that.
So and that may raise a variety of questions about both electronic medical records, the payment for electronic medical. Now, psychiatrists as physicians can get meaningful use and get paid. Hospitals can. But community mental health centers don't have access. Psychologists don't have access. And we also have this very complex issue that butts up against this, which is really around privacy and, of course, comes back to stigma. And, you know, the field, and I say the field, I mean the entire medical and mental health field, I'm not sure has come to a kind of settled view about how much one puts in, how much one doesn't. People are often uncomfortable with things being in the record. And yet we also know there's a tremendous amount of care that's happening in the general medical sector that's mental health related. We know that there's a tremendous amount of comorbidity that's kind of buried because we don't have the data either from claims or electronic medical records. How do we begin to deal with that as a policy? And this is for anybody on the panel. How do we begin to deal with that as a policy issue? Because clearly if we're going to be effective, we're not going to be effective without having real and accurate data.
So I asked the question, are we promoting stigma by saying I should not put the right diagnosis on a claim? There's a lot of beliefs and myths that once I put it on a medical claim, it's now going to make it difficult for that individual. Somehow that system is going to talk to the employer, and the employer is going to have transparency of that, or life insurance companies will have transparency of that. There are firewalls. We are obligated to put these firewalls, and they are in there. So that data stays within a certain circle and is not transparent from that perspective. But unless we, and I realize that people have concerns about that, but unless we decide that it is okay to have a mental illness or substance use disorder, and we are able to put that out there and not keep that kind of thinking of, let me protect the patient by not putting that information in. I'm concerned. I'm concerned with health insurance exchanges. Risk adjustments laws are there which will protect those who are more complex patients. There will be more money that will be allocated, but if the complexity is not documented, we're going to lose out as it relates to behavioral health. So I'm real concerned about this. This is a thing that keeps me up at night for sure.
So, Connie, you had the great experience of working in the Senate for a long period of time with Senator Kennedy and being on point for the parity law. And, you know, there had been a number of attempts in the past, including the law in the late 1990s, to move this forward. What made a difference in 2008, and also what, when you really get into the guts of the policy-making process and the legislative process, what are the pressures that you all had to deal with that we need to think about from an advocacy standpoint?
I think it was a very interesting process, and thank you for having me, by the way. I think it was a very interesting process. I was just fortunate, and the process itself was fortunate, that I think Senator Kennedy and Senator Domenici walked lockstep with each other through all of the challenges and through all of the 3 years of trying to put a bill together that would move forward from the original parity bill. And we wanted to do more in there, I think, and as Sherry said, in terms of what was the policy objective. And I think if I sat and talked to the senator, what he would say when we talked about this was there were really 3 goals. And all of them revolved, as Sherry said, around the right of people to be brought to equal that have issues of chronicity. And it happened that if you were living with mental health and substance use disorders, you were treated in a very discriminatory way within the healthcare system as a whole. It wasn't only about the payment reforms that we tried to do, and it wasn't only about the access to care. It was across the board. It was in schools. It was in IDEA. So it wasn't only about parity. It wasn't only about health care. It was an attempt to try to impact something that could be threaded through a lot of different systems that we have, whether it's employment, whether it's education, or whether it's health care, and whether it's rights, to be able to make a difference for a population that had not been brought to equal. And within the population, because there had been a history of thinking about mental health here and substance use disorders over here, you could argue, and Patrick and I had many arguments about this, is how do we bring substance use disorders to equal with mental health, which still wasn't equal with the rest of what healthcare was about was what it was about. So it was a very difficult time. It was a hard time in the Senate, but our goal was really one of what Senator Kennedy was about, which was really human rights and equity for people to be brought to equal. That was number one. The second one was to really try to get rid of the throwing of stones that the healthcare system was tending to do, whether it was stigma, whether it was not enough metrics for outcome, whether it was payment systems, whether it was access, to get the stones out of the way that we were throwing at a population of people that very ironically were trying to get access so they could be better, so they could really be better. And what kind of a healthcare system does that? Whether we did it or not, if people weren't in the system, they may not even care. But for people who were trying to get the help, we continued to throw stones. And so it was to try to do that. And the third piece of it, and I will tell you, Senator Kennedy in particular was very strong on this because this was the way he approached his policy, was we needed to do it in a way that balanced out so that the industry, meaning the infrastructure, the insurance infrastructure in this country, could accommodate the changes that we were doing. And this wasn't about we're going to do this over here and pull apart this over here. That was what his philosophy. So those were the tensions and the tug and pull that we had to do. It had been very, very controversial over the years. And so frankly, what we did in the Senate, where the Democrats actually were in the minority and the Republicans were in the majority, and President Bush was in the White House, and the House was was all Democrat, and so it caused that tension as well. Because what you could do in the House of Representatives, you couldn't even get close to bringing over to the Senate most of the time. And so really it was about what happened in the Senate because President Bush would have to sign it. And so what we decided to do was to actually bring in the groups that were the most resistant, and so, or seemed to have been the most resistant. So we brought in only the insurance companies and only in the employers. And for the mental health community, we said you need to wait. Because we know what you want, we agree with what you want. We need to understand what the problem is with the people who really drive this system, which are the employers and the insurers. So Domenici's staff and myself, we sat down, and for almost, I would say, for you all who were in the back of the room who were there, for 4 to 5 months, we just sat in that room, much to the chagrin of many of the advocates who wanted to be in there. We knew their gig. We cared. We were going to carry that water. What we needed to understand was why, to your question, why was it so hard to have that happen? And I know you wanted some stories, so I can always throw in stories, right? So I'll give it. So the very first meeting we have, and it was very difficult for me because I had to listen to a half hour of, kind of adversarial conversation about the office I came from and his position on everything. And fine. So after a half hour, I said, "Are we done? Are we done? Are we finished?" And they said, "All right, we're finished." So this went on for a couple weeks, and it was fine.
This is like long-term psychotherapy.
Yeah, right. It was fine. Go ahead for a half hour. For a half hour, just beat me up, and then we're going to go move on, right? So we finished up on that. And then I asked them a different question. I said, and this was a really interesting conversation. I said, I need to just ask you a question, and it's got nothing to do with working here. It's got nothing to do with Senator Kennedy. It has to do with working as a practitioner in the hospital, which I did then and I still do. I said, so on the weekends when I cover the house, meaning cover the whole hospital, and it's a pretty big hospital in this area that I still am in, I said, I can tell you that every single time it gets to be right near Christmas and New Year's and the Jewish holidays and Thanksgiving, all of a sudden everybody's run out of their outpatient benefits. So they're in the emergency room, we're admitting them to the unit, they don't need to be there, and this is to the insurance company. So I said, I need you to help me understand what you gain out of that. I really want to understand what you gain. I know I don't have any beds left. I know your utilization review people are going to come and say, get them out of here, they don't need to be here. And you, the employer, you want everybody's pencil sharpened January 1st. So you now have a dysfunctional family, you have a person who hasn't really ready functionally be able, and you want the pencil sharpened. So I said, so please someone argue with me why this was okay to do. I said, so I would like to understand that. Well, we had a very interesting conversation. I'm not sure whether you guys in the back were in that original meeting when we were having this conversation. And first it was, well, you know, and I will tell you this because you need to know it in terms of the obstacles. They said, well, you know, there's a problem because with mental health we don't have any metrics. We don't know what the outcomes are. And so, you know, we've spent a lot of money over the years. What's this business with horseback riding? Okay, now this gets into the IDDD population that we still need to talk about here because they are part of mental health. And mental health threads through everybody. I don't think of it as silos, and I'd hate for this session to end in silo. And so we need to thread that through. What is this? You know, we can't do this. And I said, well, wait a minute. Explain something to me. In the 80s, you came into the system of managed care. You came in, not managed care the way we know it, but managing your services. You were able to do medical necessity. I said, you got the tools in the toolkit. So now you're hitting this group up twice. Maybe what you're saying is true. I don't know, but you're hitting them up twice. Why are we doing that? And they said, and on the other hand, you know, why am I worrying about what's going on in the hospital when they need some outpatient help? Well, we had long conversations about this back and forth. And I said, now let's talk about the money, just for a minute. I said, now let's say I have a brand new diagnosis of ALS, which is Lou Gehrig's disease, neurodegenerative disease. Okay, and I wind up going to the neurologist. Well, you're going to pay 90 cents on the dollar if I'm in network, 80 cents on the dollar, maybe 50 cents on the dollar if I just go where I want, right? But then I go down the hallway to the people who are going to help me reduce the dissonance between who I am today and who I very well may be 5 to 10 years from now, where the only function that I have left are tears running down my face. So I said, tell me why they are not entitled to be able to have the same reimbursement to a doctor so they have access. It's not about the money. It's about what happens when there's no access. So I said, why is that any less important than when they go to the neurologist? Well, they couldn't answer that question. So we got away from the policy conversation, and we just got into real people examples of what can we do different. And the actual beginnings of the parity resolution started with, well, maybe we should give you some more visits, and we'll give them to the employers, and then they can have like a pot of extra visits at the end of the year. And for people that need them, they could access the extra visits. And I said, so that means I knock on the door on the week before Thanksgiving, and I say, really got to have some extra visits. Can you dole me out a couple tickets? I said, that's not going to work. But it was the beginning of the conversation that evolved into the parity agreements that you saw. Over time, I will tell you, we could never have done this. For all of you who tend to be more on the critical side, we could not have done this without the investment of the insurance industry that was there and without the investment of the employers. And after all the years of being a nurse and a nurse practitioner and nurse manager and everything else I've done in the hospital systems, I finally realized that the employers are the one holding the key to this. The insurers will give you anything you want as long as you want it and you'll pay for it. And I don't mean that in a negative way. But you'll put the package together that I want. Right. It's the employers. It's the employers that we needed to care the most about, and we hadn't done that. And I will tell you, it got tough in the Senate. It got very hard, particularly when, and then we did, the mental health groups came in. They were fabulous. We worked as a team. And my boss said, you never budge off of any agreements that we make in that room. Never budge off of them, because that's what's going to make this work over time.
Meaning that they would trust what they
yeah, once you brought that coalition together and once we made an agreement, you stick to that agreement, and that's the end of the story. And so we did have the mental health groups, we had the insurers, we had the employers, and we worked together on how we could get at least the beginnings of this. Was this important? We made a decision. You couldn't do this, as Sherry said, in ACA, in a healthcare reform. You had to do it the year before. Now, the one story I will tell you that Kennedy was really interesting is we were walking, and he never, until the very end, understood that we did not mandate already. in health insurance that mental health and substance use at least be covered. Not what was, but at least the category would be covered. And one day we were walking, and Teddy knows this, he has a very loud voice and boomed and everything. One day we were walking around one of the buildings, and he said, tell me some more about this parity thing. And I said, well, the one thing where we're stuck on this is even if we get this done, it's if you have this in your health insurance package. If you don't, or if you want to take it out, as Sherry said, you could do that. If I had 50 guys chimney sweeps in my business, and I said very well that the boss could come and say, hey, I covered 9 different things for you in mental health by our plan last year, but they put these new rules in, and I'm sorry, we're only going to cover 2. And so he said, or they could say they don't want to cover it at all. And I remember him getting so angry in the Hart building and screaming at me in that loud voice, what do you mean? And this is like 2 years into it. It's echoing all over the place. And he's like, what do you mean? You mean to tell me that health care plans don't have it in already? And I'm like, no. He said, and what are we doing? I said, they can't sell it in the House. I said, Patrick can't even sell it in the House. I said, we'll never get it in the Senate. Oh, and the scream, and everyone's looking at us, and I'm going, oh my God. So he gets in the elevator, and I waited to get into another elevator because I didn't want to go in because I knew it was going to happen. He was great. He was awesome to work for, but man, when he was mad, you knew. So I get out of the elevator, and there he is standing. I said, I thought you knew. Well, I didn't know. Well, I said, but it's going to be all right because when healthcare comes, we'll be able to do it. But we spent an awful lot of time together, and I think if you ask me why was it different, it was different because we, honest to God, I honestly believe, you tell me if I'm wrong, you guys, gave a fair shake to all of the stakeholders that needed to be at a table to make something work. And it was in the beginning, and it went all the way through. When it was time, and this was interesting, when it was time for us to then try to conference, sort of, or get together ahead of time with the House before we actually did it for real, we went over to the House, but we brought the whole team. So they were like, what are you doing? This is supposed to be for staff. And I said, I said, if you want a conference with us, I said, I'm bringing the whole coalition in here as well with you, the staff, because that's who you got to negotiate with in the end because we agree with everything and we're standing with it. And so you may as well have them in there at the same time. So that was a strange kind of an event, but we all went over, and there was the coalition, and there was the staff from the House. And we were able to get that bill. Well, the irony was, when the bill was ready to be passed, there was all, what are we going to do with it? Well, it became the base for the bailout. And so the people came and they said, do you mind if we ride the bailout, the big bailout that we've heard about for years, on mental health parity? Yeah. And I said, well, I guess not. I guess you could do that because I'm sure if I'm in trouble enough to get bailed out, I probably do need the mental health. So I said, I guess there's a consistency with it. And then this gets better, and that's the end of my story.
So we didn't know this meant parity for AIG.
Yeah.
It all rode as one big package, so it was going. And I remember that the Budget Committee called me down, and this is where we need to work on this issue as a broader issue. We need to work on it within the interest of health care. It's sort of like Ryan White. I say to the HIV/AIDS committee, don't say the word Ryan White to me. Talk about what the guts of it are that need to be rolled into a reformed health care system. Because a lot of these bills were done because we didn't get what we needed to be equal. Now we ought to be equal, so we need to move it in. But anyway, when it was getting time for the bailout thing to be riding, and this is where everybody worked to make something happen. The Budget Committee called me down, and they said, Connie, we're going to give it to you. We'll put it on here, but you only get 2 years. Because remember, the bailout was 2 years. I said, this is not going to happen. I said, no, because it's going to take a year to make anything happen because of the plan years. We can't do that. So I said, that's fine. I said, but just remember, and I would ask all of you, just remember that mental health and substance use isn't just about the diagnostic categories that wind up in the psychiatrist's office or the social worker's office that are very clean. It threads through all kinds of stuff, and it really threads through the disability community because there aren't people who don't have a functional limitation as a result of a disability that don't run up, at least against transient mental health issues as well. So it's not just that one label. And so, let me finish. Yeah. Okay, so so I left. No, they'll like this. Right? This is not researching. I'm here to not do the researching for you. So I left, and what I do is I called the disability community, and I called the folks who generally are in wheelchairs, and they're very active, and they do civil disobedience, and they do all this stuff. And I said, and they were somewhere else, and I said, do you have a couple folks that would come down and not do anything, just kind of roll up and down the hallway. Just roll. No reason, just roll. You don't have to do anything. But for some reason, everybody gets nervous. I'm not sure why, but they do. It works. So they sent 30 people down, right? And 30 wheelchairs come in, and they're just rolling up and down the hallway, right? So I go to my boss, the next guy up, the policy guy, and I said, here's what they offered. We're not going to take it. He said, no, take it. Senator Kennedy will like it. I said, no. He said, take it. I said, give me till 6 o'clock. 6 o'clock. If we don't have it by 6 o'clock, then we'll take the 2 years. So they're rolling and rolling. Well, anyway, about 2 hours later, the budget committee called, and they said, they'd already done their press release. It didn't really matter. They said, all right, we got it. We're done. We're doing it. You're going to get parity in perpetuity. And I said, really? And they said, now, can you get the people out of the hallway? Well, I forgot that they were there. And the person who was our admin assistant was leaving to go home, and she calls me up and says, hey, your friends are all getting hauled away by the police. And I'm like, oh, no. Right? So a couple minutes later, I said, well, we have 7 kids, and one of them has a disability. I said, well, I guess she'll be contributing to the cause of what it takes to get people out of jail. That's what it took to get parity. And that was when it was able to go through.
Great
and we
story.
got it. So these are the things that you don't see in the end. And I will tell you, what I was most impressed with was Senator Kennedy spent 1 full day with me. We went house office by house office, every single office where he made the case for why this was important. Didn't matter whether you were a Democrat or Republican, this is why it was important. So we got a very good vote. And the regulations, I would say, at least the ones that are out there now for us to take a look at, are very, very consistent with what the agreements were. I mean, they are consistent. And, for our benefit, we stick with what the agreements were, because that's why it mattered. And so that's a little bit of the background.
First of all, thank you for the story, but more importantly, thank you for the work that you did on this and making this happen.
A lot of people did it. A lot of people.
So we're into the question and answer period now. There are microphones here that folks want to come up, and hopefully we can continue this conversation among all of us for the next 15 minutes or so. And please introduce yourself.
Okay, I'm Susan Lazar. I'm a clinician from D.C., and the microphone's too tall for me. Very interesting. I want to thank you for the panel and for these wonderful comments. I agree with Dr. Beal that we're thrilled, really, with the visit limits. We're outlawed. But I do have a question because what has happened in managing outpatient care is with the NQTL exception, we have recognized clinically accepted standards of care which are quantitative, not non-quantitative. And we have standards that, as I have encountered them in the denials I've gotten as a clinician, are not evidence-based. The recognized clinically accepted standards of care that are employed frequently by insurance companies in review are not research-based. And also there are algorithms that limit the numbers, end up limiting numbers. One company reviews automatically 20 visits in 6 months and very routinely doesn't allow more than once a week treatment except very briefly, which in my having reviewed the literature actually on the cost effectiveness in psychotherapy over the last 30 years and having published rather extensively on it, I have a different perspective on what's appropriate. So I wanted to ask about that, how this ended up to be quantitative and what the reasoning is behind it. It's been hard to access. It seems to me, Nora Volkow said in the last session, that patients with mental illness are not getting the treatments for which there is evidence. And then just one other quick question, because there was a suggestion about moral hazard, although that term wasn't used with respect to psychotherapy. And, the RAND study found that there wasn't. And also there was a Champus study that Alziance did showing that in the military, when outpatient visits were opened up, there was a tremendous cost saving in inpatient hospitalization. So those 2 questions and comments.
So we've got a couple of different questions. Maybe we can start with the issue of quantitative versus non-quantitative limitations. And then if we have time, move on to demand or else move on to other questions.
So let me see if I'm understanding your question. What I'm hearing you say as it relates to outpatient treatment, that there is a quantitative factor that's used in order to do authorizations, and is that what you're saying?
Right, and that the standards are not research-based, and
Okay, so that's a pretty involved question, so let me answer it this way, okay, which was not going to answer everything, but it certainly will give a framing or at least an approach. The parity law says to be comparable with medical, okay? And in looking at medical, there are many methodologies that are used to determine when a utilization management needs to be employed. Things like increasing trend without any real reason as to why, or introduction of a new type of treatment where there are a lot of alternatives and there's difference in the cost of those alternatives. These are some of the reasons why a utilization management technique may be employed at that. So there's a lot of reasons behind that. In looking at outpatient psychotherapy, and this is kind of the area that I know is going to be the rub, and this is also the area that we identified through a process that we put in place where we invited all the subspecialty organizations and consumer organizations to come together, and we also sent out to policymakers a survey in terms of interpreting the parity non-quantitative treatment limitations, and we specifically honed in on the psychotherapy issue to find out what people's thinking was on that. In looking at that, it was very clear there was a lot of differences in opinion on this one. When you look at medical, they will look at certain services and they will apply certain techniques to manage utilization. And those techniques need to be aligned with what the service is. So, for example, you would never put pre-certification in place for a normal pregnancy or a delivery. It doesn't make sense. But you could put a pre-certification process in place when you have, like I said, a variety of different options, and there's differences in the cost of those options, and there's no difference in outcomes. So or they're being used in a way that is not following guidelines. So the use of MRI for low back pain when there's other alternatives, a pre-cert may be put in place. The difficulty in looking at psychotherapy is there are many different techniques that are being used. Our CPT codes don't tell us what techniques are being used. So there might be a difference between a cognitive behavioral approach and a psychodynamic or a psychoanalytic or screen therapy or whatever Joe Blow's therapy that's out there. So there's all those differences that are going on. So it's very similar to other types of therapies where there are multiple different ways that something can be approached, and the CPT codes are not very descriptive or informative as to what's really going on. So I admit, yes, there's a difference between a CBT approach and a psychoanalytic approach, but if one doesn't know what's going on in terms of what's going on behind those closed doors, the only thing you can do, which medical does, is that take a look at what's the average length of treatment by certain diagnoses, and they would pick out something like the 95th percentile. So if someone goes beyond the 95th percentile, then that would be the time that they would reach out and try to understand what's going on. So that's where the quantitative piece comes in, because medical will use that distribution curve, find a place on that distribution curve, and say this is where we're going to reach out. So through the FAQs for parity, it has helped us to say this is how we'll do it, and the transparency around that is we have to document that we're using the same kind of thresholds, the same kind of distribution curve, and that's how it goes.
Thank you. That's very helpful. Question over here.
Hi, I'm Christy Barber, and I am from Connecticut. I'm with the Region 2 Regional Mental Health Board, which is a grassroots advocacy we were put in place when they started to close the hospitals, psychiatric hospitals, in '75. I'm actually located on the CVH campus, Connecticut Valley Hospital campus, where my office is, which at one point housed 3,000 patients in the early 1900s. But one of the two things I just want to point out, one is that I think that there are challenges around the disclosure of mental health conditions, and you mentioned the severity levels of the mental health condition. A woman who I work with, she actually was denied health insurance because of her mental health condition. So that's one element that I think is a challenge, is that there are repercussions for some of, for the mental health condition severity issues. And some people feel when they go to a hospital and they get treated, if they are there for a medical condition, even if they say they have a mental health condition, A, they're treated differently, people don't necessarily want to treat them because they're afraid of the mental health condition. So there are some complexities then where we have areas to grow in that. The other thing I wanted to mention in terms of parity is the reimbursement rates for mental health are different than medical. And in mental health and addictions, it's not one particular roadmap, and I think that's in the mental health community. We think about vocational, educational, the different supports and the different continuum of conditions, but that the reimbursement rates are a challenge. Like in Connecticut, they were going to cut $50 million from the grant-funded monies because of Affordable Care Act. That's the other thing that can be challenging is, where the providers, we did get some of the money back, but that those are some of the challenges when I look at equities.
So to the reimbursement issue, because it's, I think, a very important one. So there are hospitals all over this country. I mean, somebody mentioned in an earlier panel, one of the wealthiest hospitals in California closed their psychiatric beds. There are hospitals all over the country where patients who are awaiting psychiatric emergency hospitalization, where there's no question in anyone's mind that they need to be in a hospital. That this is not a question of do they meet a threshold. Everyone knows that they meet that threshold. It's simply a question of finding a bed, and it can take 2, 3, 4 times longer than finding a bed for someone with an equivalent medical surgical condition. There are hospitals that have no psychiatric beds in general hospitals who are sending out the equivalent of 20 or 40, the equivalent of a 20 or 40 bed psychiatric unit filled per year out of their hospital, in part because of perhaps stigma, but certainly because the reimbursements compared to orthopedic care, surgical care, even general medical care are much, much worse, and people will lose an enormous amount of money on them. Does the parity, is that something that we can monitor? How does that play into both either the ACA or parity, or is that not something that really is envisioned within that context?
So neither parity nor the ACA has anything in them that would specifically address that issue, because reimbursement is not covered in parity, and it's not covered in the ACA either. And of course, reimbursement has multiple public and private components, many more public and private components here than in traditional health care, because there are also grant-funded programs which really don't exist. So there's just a multiplicity of reimbursement mechanisms. I think this is just an example of a place where policy so far hasn't addressed all the questions, and we need to keep looking to see what we have to do next. I don't think that the existing policies will address that.
So I think you were next over there.
My name is Pat Taylor, and I'm with Faces and Voices of Recovery. We're a national organization of people in recovery from addiction, family members, friends, and allies. And I wanted to raise another public policy issue and get your thoughts on it that we believe will have an impact on the ability of people to get well, and also on how we understand the effectiveness of the care that so many people are now going to have access to, which is because of the criminalization of addiction, we have many discriminatory laws that keep people from getting jobs, housing, and other social supports that are critical for people to sustain their recovery. And our thought is that if we don't address those discriminatory policies, when people get help in the health system, millions and millions who haven't had it before, when they try to get their lives back on track because of these discriminatory policies, they're not going to be able to, which has nothing to do or say about the system of care that they are going to be getting and experiencing because of these incredible changes in terms of health services. So I would love your thoughts in terms of making sure that that other equity public policy issue is addressed at the same time that we're working to provide so many more people access to care.
Tom, do you want to take that?
Well, I have to say that I think that's a residua of decades where we didn't understand addiction. When they created a treatment system, even before they created a treatment system, addiction was clearly a criminal justice issue. It wasn't a health issue at all. Really, it's only the Vietnam-era war that brought addiction into healthcare, because it was simply politically unpalatable, untenable to have returning veterans with substance use issues labeled as criminals, that you had to do something with them. But the whole idea was it's bad parenting, it's bad self-regulation, it's poor self-control. Let's teach them a lesson. And so all of these laws were passed, and you're right, they're not merely stigmatizing, they're discriminatory. You can rob a bank, do your time, get out, and then go into public housing. You rob a bank for the purposes of obtaining cocaine, you'll never get public housing. You're not allowed. It was all in a misguided attempt to prevent others from going down the path of substance use. It didn't work. It has to be corrected. I know the Justice Department is trying to make those efforts, but it's undoing an awful lot. And the ideology remains, even despite the fact of brand new knowledge about addiction.
Thank you. Yeah.
Notice that I have described the problem to you. I have not given you the answer to the problem, but we're in the same boat.
We just do for a couple of other people waiting, so thank you. Middle microphone.
Hi, I'm Susan Weinstein from Families for Depression Awareness, and I just wanted to thank you for making sure that families are at the table and we have issues that are federal and state when we're trying to advocate for our loved ones to get care. Involuntary treatment on the state level, HIPAA on the federal level, access, and all those things. We've translated some of our concerns into a project with Depression and Bipolar Support Alliance that we do a blog called Care for Your Mind. There we're able to take the personal stories of people affected by mood disorders and relate them to the policies that are being talked about. So we're finding that to be a very useful mechanism for informing people about what these general ideas of policy mean in practice. One of the things that happened recently is that people were really surprised to learn that parity didn't mean equality. So we've been able to point that out, and hopefully we'll steer towards some better answers there. Right now, our program is focusing on access issues with the hope that at some point we'll be able to turn to the quality issues.
So just in terms of the folks.
Yep, that's my last sentence.
Is there a question?
So I'm just wondering when it is that you all think that we're going to be able to start looking at quality more than access. Thank you.
Anybody want to take that?
It could be rhetorical.
I think there are two ways to think about looking at quality. One of them is to look at process quality, and there have been some efforts, NCQA and other places are thinking about process quality measures and trying to incorporate them. And the other one is to look at quality outcome measures. How are people actually functioning in the community? That's, to me, the gold standard. That's where we want to get to. It also changes our focus from what happens at a particular visit to how is a person living and how are the structures of their life, which I think is the way you want to do it. We're not there yet, and it's an ongoing project.
Ma'am, and just try to limit it to a question if you could.
Sure. I'm going to cut to the chase. Hi, I'm Janine Francolini, and I'm the founder of the Flawless Foundation. We work in children's mental health and prevention. And I understand the historical significance of being aligned with the intellectual disabilities community today. I'm wondering what are the pros and cons of us aligning with that community, and do they want to be included with us? And, for example, someone with Down syndrome doesn't have, most of the time, doesn't have a mental illness diagnosis. So why are they, what are the pros and cons, and is this historical, or what are we doing?
I think, let me try. I think one of the reasons that you want to see those two populations align in the sense of working together on issues that matter is because both groups are interested in functional outcomes. They're interested in understanding how what is it that they need that helps them function better in the community. Is it jobs? Is it keeping marriages together? Is it keeping kids in schools? Is it what? And both populations are really interested in that kind of piece. And that's important in terms of even what you're talking about. When are we going to get to quality versus access? And everyone says, well, the electronic medical record may be the way. Well, maybe it is. And maybe really meaningful use is. And maybe someday the Office of Meaningful Use, if we talk to them correctly, will put the correct indicators in there that will give us the information that we need so that the access issue will be very clear and quantitative. and then the quality piece will go either hand in hand with it, or at least we'll have some results to do it. But I think it's the same common issue. I mean, I think that the issue, that the living conditions and the living standards that people who are struggling with mental health or living with mental health and substance use disorders around function in the community is the same struggle that the developmental disability community is having, and frankly, in some respects, not quite as much, but at some level, the HIV/AIDS community is having as well. So I think there's ways to align. I don't think it's everything, but I think there are thematic pieces.
But let me just, because we have to get, let me just do one other piece related to this. You know, I think the other thing we need to remember is what we call a mental disorder doesn't necessarily mean it sits in some corner or box over here, or necessarily because it has a mental representation, in other words, thoughts, behavior, emotions, it doesn't say anything about its cause or its etiology. There are a whole host of medical conditions, some developmental disabilities among them, other endocrine disorders, calcium disorders, a whole host of medical interactions that cause a host of mental symptoms of various kinds. So we need to be very careful and precise as we think about this, because ultimately we're going to have to find the underlying mechanisms of these things, and they may come together in ways that are very, very different than what we think about. They're single genetic abnormalities may change behavior within developmental disabilities in one direction or another, and there's evidence for some of those as well. So,
and it may not just be developmental. I mean, it's really interesting if you look at the data of the number of young people, even in special ed, who have the diagnosis of ADD, ADHD, and the gravitation towards the drug culture. So I mean, there is connections with the disability. Let me say the disability community as a whole, and everybody's under the ADA umbrella too.
So last one is Dr. Young. Last question.
Thank you. I'm Mindy Young. I'm one of the officers of the American Psychiatric Association. I'm also in private solo practice of child and adolescent psychiatry in California. So I live this stuff on the ground. We're talking about big ideas here, but these are federal programs, these big ideas. I think to some degree we're missing what's actually going to happen, which has to do with implementation in the states, in the individual states, with their different benchmark plans, with their different appreciations of what's parity, of what the ACA is. So my question is, how will we, or how can we actually transmit these ideas to the states? Who's going to speak to the big ideas within the states? Who's going to institute any of the changes? And where will the accountability lie? This sounds great, but my concern is we have different states. We have 50 different states. How are we going to know that this is playing out?
Sherry, you want to take that as the last?
Yeah, I mean, I think that there are positives and negatives of doing this at the state level. And the positive, which I think is a question, the positive is only available if we take some steps. And the steps have to be, we need to be collecting information, we need to know what's going on in the states and what the outcomes are for people with mental health problems in the states. So actually ASPE's got a big project working on exactly that with respect to Medicaid, trying to see what the state actions have been and what the effects are on people. And it's only really, I think, by doing those kinds of comparisons, because the truth is we don't know exactly which policy is the right one to pursue, that we will actually be able to learn from one another. So I think that's the hope. And it's hard to do it. It's not as hard in California because it's a big state, but the smaller states are difficult. We got to do that.
Tom.
Just add, we talk a lot appropriately about state policies and government interaction. Don't underestimate, at least in the substance abuse field, the emergence of an industry that's never been there before. With ACA, there's now tremendous interest in creating new alternative ways of treating substance abuse. Large investment organizations are putting literally hundreds of millions of dollars into this. So they're not going to throw that money away, and they're going to figure it out. I don't know what the answers are going to be, but my point is, with ACA and with parity, you have market forces that far surpass scientific forces and even some of the other forces that are at work.
So we're just at time for lunch. I want to thank the panel for a wonderful discussion.